think our main challenge is to present with the two of us and managing not to look like the two runners at any point, but I think we've probably already failed. So Nick and I piloted a course with Millsy, who's sitting in the audience, sort of looking very comfortable actually, and ran it earlier this year. And so this is just a little bit of a description of why we did it and how we did it.
Okay, thanks, Helen. So why did we choose this to develop this course? So there's plenty of evidence that people with severe mental illness die 15 to 20 years before the general population. And part of that reason is that people with mental health problems tend to present later to acute medical services, and also because sometimes their symptoms can be diagnosed as related to a mental illness, so they don't get a diagnosis until much later, and there are lots of other reasons as well. There's also evidence that in acute hospital settings, mental health is not addressed, and that's partly why there's a huge drive now to develop liaison psychiatry services in all acute hospitals by 2018. Medical and nursing staff in acute hospitals generally feel that they don't have confidence or skill or training in assessing mental health problems. And there are particular gaps around the legislation that can be used to treat mental health problems, including patients who lack capacity, which pose challenges for acute hospitals, partly relating to patient care, but also relating to kind of clinical governance. And that all those things together mean that clinical care can be compromised.
So this is our planning session that we had. I've been given a laser to use, and I'm going to use it. This is a photograph, for those of you unfamiliar with modern technology. So this is the planning session that Nick and I had with one of the actors, who I also happen to be married to, handily enough, for the funding. That's not actually the office at Newham, although it could be. That's actually my house. And we had a planning session where we took it in turns, having the laptop plugged in and the light plugged in. But we drank some wine, and the scenario quality improved throughout the course of the evening. What we wanted to decide was what we wanted our learning points to be for the learners who attended the course, and we wanted to think a little bit about how we would deliver that, whether it would be purely simulation-based or whether there'd be any didactic lecture components of the course. We decided for our pilot that we would just use scenarios, that we wanted to teach people about common mental health presentations to an emergency department, but also for people who worked in a ward scenario, but also for people who worked exclusively within the Mental Health Trust. We also wanted to cover the relevant legal aspects, so DOLS, the MCA, the Mental Health Act, and so we had a planning session to decide how that might best be delivered, and we also had to think about whether or not we wanted to do anything around physical breakaway techniques and de-escalation techniques that people who work more in the medical side of things might not have had any familiarisation with. So that was our planning. We had to think about who our target learners were, and we asked around and spoke to people about who might be interested in doing this, and essentially everybody that we spoke to said that they would be interested in doing it. So our target learners essentially were pretty much everyone. The course that we ran on the pilot day, we had 14 people attending. It was a mix of, there were 6 doctors, there were 6 nurses, there were 6 people from RAIDS, which is our mental health assessment side, and there were 6 people from either the ED or foundation trainees who worked on the wards. There were some core psychiatry trainees and some ED nurses. So in terms of multidisciplinary, it really was, because it was a mixture of doctors and nurses, but also it was a mixture of different skill levels, but also people who worked exclusively within mental health, and then people who worked in the emergency department, but also other areas of the hospital.
Okay, so as you can see, we chose a kind of variety of different scenarios, and so these cover the main kind of psychiatric emergencies which present in acute hospitals, particularly to emergency departments, and of course all of those kind of situations are included in the curricula for core medicine, emergency medicine, and core psychiatry. The way we ran the scenarios in the end was we decided not to have any didactic component, but to use the scenarios and the debrief to draw out the key learning points and, for example, issues around Mental Capacity Act legislation, or how to use the Mental Health Act, or how to distinguish which act is important. you can see in this slide, the actor is simulating a patient with mania who is sexually disinhibited, and this is actually one of our very experienced liaison nurses who found this scenario quite challenging. So as an example, it really drew out some of the human factors and the particular issue in mental health about paying attention to how you are actually going to conduct an assessment. Because this nurse, at a certain point in the simulation, found that she was in a position where she wasn't able to leave the room without going past the patient, and in a real-life situation, she would have been at risk. So we sent a doctor in, a male doctor, to join her, because that would help kind of contain the situation. But one of the things we found was that the junior doctor, who actually worked in A&E, so had little experience in mental health, actually started to take over the assessment, which actually wasn't what the nurse, who was perfectly competent doing the assessment, wanted. So that was really helpful to kind of draw that out and for everybody to see that and to start to understand the importance of communication and handover before you start assessing, particularly patients who may become aggressive or threatening. Then we also did some de-escalation, as Helen mentioned. So de-escalation and breakaway are taught to all clinical staff in mental health settings. De-escalation is essentially being able to identify early signs that patients may become aggressive or more agitated, and taking steps by modifying your body language or tone of voice, rate of speech to calm patients. And this slide shows the importance of proximity. So here, half the candidates are asked to form a row, and the other half approach them and are instructed to stop when they start to feel uncomfortable. For most people across the world, an arm's length distance starts to feel uncomfortable if people come closer than that. There's a bit of variation here, but of course you always see that. But one of the kind of learning points that came from this was actually, that particularly for staff in acute settings, was the understanding that people who are psychotic or agitated, for those patients, you need to increase that length, that distance, by about 3 times, otherwise patients may feel threatened. And that kind of links in with the kind of early warning signs as well. We also did basic breakaway techniques, which we'll talk about on the next slide. Thank you. So again, breakaway techniques are taught to all clinical staff in mental health settings. So these are basic techniques that are safe, don't cause injury to people or patients, that people can safely get away if a patient grabs onto someone. So we taught just a basic introduction to some skills. In mental health settings, you would also teach people things like if someone grabs your hair or grabs you around the throat, how you can safely escape, which is obviously quite difficult if someone's got you around the throat. But what we didn't want to do is make people too confident that they could manage difficult and complex situations when actually the correct response is to leave the room. But the feedback was that people generally found it quite enjoyable.
So as it was a pilot, we tried a couple of different things. Back to the pointer again. So we started off in the simulation suite, where the scenario would happen behind a 2-way mirror and the rest of the group would be observing. We started there because it was our comfort zone and we knew what the sim suite looked like, so we thought we'd start there. And then later on in the afternoon, we moved to the lecture theatre, which is a much more open space, where you've got the scenario happening in the middle, and then you've got the observers sitting in a group around the outside. This kind of split the group in terms of what people preferred. So in the sim suite, the people who were in the scenario found that they felt less observed and were more able to engage with the scenario as it unfolded. And in this group, in this setting here, the people who were actually observing felt much more involved with the scenario and felt that it was useful in other ways. The disadvantage to this one is that obviously if you're sitting around the back here, it's very difficult to pick up on the nuances of stance and facial expression in either the actor or the candidate as it goes on. So if we did it again, I think we might do it again, that we use both different settings to do the scenarios, because there were definitely pros and cons to both of them. Feedback, I feel a little bit like I feel about general elections, in that I understand it's a democratic process and it's important. However, some people shouldn't be trusted to have an opinion. in particular, one candidate who answered all the questions kind of the opposite to the way that we would have liked. So he said, did this improve your confidence in making mental health assessments? No, it gave me complete confidence. And it's just like, just answer the question in a way that we can meaningfully put into a pie chart. So we did have some very useful feedback, some rubies in amongst the dust of general stuff criticising the quality of lunch. But everybody found that it was very helpful in terms of their mental health assessments, especially the ED staff. The breakaway and de-escalation stuff that we did in the afternoon, again, split the room in that the people who came from a mental health background didn't particularly find it helpful because they routinely would have this kind of training, whereas people who work on the wards, who work in the emergency department, found it extremely helpful because thinking about those techniques was something that nobody had ever thought to mention to them before. But everybody very much enjoyed the fact that it was multidisciplinary, and everybody very much enjoyed the fact that it was a day that was entirely about psychiatry and mental health, which is not really covered that well in medical curriculums in other areas.
So where do we go from here? Definitely forward, not back. We're developing a bank of scenarios to cover other situations, patients presenting with dementia, patients with intellectual disability, things which are otherwise difficult for people to get experience in. We are also offering the course to senior medical staff because they would prefer to do it without more junior staff around because they won't feel so silly if they get things wrong. So there's been a lot of interest from consultant physicians to do that course. It's already been accredited by Royal College of Emergency Medicine for CPD. The Royal College of Psychiatrists has also expressed an interest in running it there, and we're in discussion with them at the moment. We're also developing specific courses around, at the moment, around HIV and mental health, and that would include things like difficult communication, so what to do if someone reacts quite badly to a new diagnosis of HIV. People in HIV clinics quite often present with some suicidal ideation, and how you can assess that and manage that safely, for example, and that would again be to a range of staff from kind of health advisors and counsellors up to the doctors in the HIV service. And the other thing, just before we move on to that one, was actually developing some pre-course material. That was part of the feedback, that some people would have liked additional material to take away. Would quite like to develop an app for that, but I don't know how to make an app on an iPhone, so if anyone does, I heard there was a good talk about it this morning. So.